Good morning, and thank you, Chairman Brady, Ranking Member McDermott, and members of the subcommittee. I'm Mark Fendrick, a professor at the University of Michigan. I address you today as a primary care physician, a medical educator, and a public health professional. Mr. Chairman, I completely agree with your statement that the current structure of the Medicare benefit is outdated, confusing, and in need of reform. Moving from a value-driven to a value-based system requires both how we pay for care, but also how we involve consumers to seek care. With some notable exceptions, most U.S. health plans, including Medicare, implement cost sharing in a one-size-fits-all way, in that beneficiaries are charged the same amount for every doctor visit, every diagnostic test, and every prescription drug. As Mr. Hackbarth just mentioned, asking Americans to pay more for all services results in decreases in both non-essential and essential care. While this blunt approach may reduce short-term expenditures, noncompliance with high-value services often leads to adverse health outcomes and higher overall costs. This is penny wise and pound foolish. Conversely, asking Americans to pay less for all services can lead to the overuse of harmful services and those that provide little value. The concept that medical services differ in the health benefits they produce is referred to as clinical nuance, and clinical nuance should be utilized in the reallocation of medical spending. Mr. Chairman, does it make sense to you that my Medicare patients pay the same co-payment for a life-saving cancer drug as a drug that will make their toenail fungus go away? Due to the lack of appropriate incentives, Medicare beneficiaries use too little high-value care and too much low-value care. It's common sense. When barriers to high-value treatments are reduced and access to low-value treatments are discouraged, we attain more health for every dollar spent. Medicare is a key component to our nation's commitment to our elderly and disabled, and it must be sustained. Even with the recent advances regarding to preventive services, as Mr. McDermott mentioned, traditional Medicare allows little flexibility to implement clinically driven benefits. Specifically, program administrators cannot lower cost-sharing levels for services recommended in clinical guidelines, and they are also limited in the amount they can increase coinsurance rates for a harmful procedure. Since changes to traditional Medicare are difficult, an interim step could be to legislate changes to Medicare Advantage. Today, the tools available to MA are also blunt instruments. Legislative and regulatory restrictions prevent clinical nuance in MA, including the lack of flexibility to steer patients to high-performing providers and a very rigid benefit design. To this, I recommend the following recommendations. First, MA plans should have the flexibility to vary cost sharing for a particular service according to where the service is provided and by whom. The Commonwealth Fund recently estimated that nearly $200 billion in savings would accrue to Medicare over the next decade if we were to develop a value-based design that encourages Medicare beneficiaries to obtain care from high-performing systems. Currently, MA plans use provider networks, but they are limited in how they may vary cost sharing within that network. This restriction forces MA plans to either exclude low-performing providers completely or permit complete access to them. There is no intermediate step. Second, MA plans should have the flexibility to impose differential cost sharing based on evidence. There are evidence-based services that I beg my patients to do, such as critical treatments for asthma, diabetes, and depression. There are also other services that are harmful or unnecessary, and according to the literature, these services account to nearly 20% of Medicare expenditures. Last, MA plans should have the flexibility to set enrollee cost sharing based on clinical information, such as diagnosis. MA plans are currently constrained by non-discrimination rules that prohibit different benefits for targeted subgroups of beneficiaries. Even though the clinical appropriateness of a specific service may vary widely among MA enrollees, cost sharing for any service must be the same for everyone. The flexibility to enroll cost sharing based on scientific evidence and clinical information is a crucial element to the safe and efficient allocation of Medicare expenditures. So as you consider changes to Medicare benefits, it is my hope that you will take the common sense step to allow MA plans to vary cost sharing on the amount of health produced. Despite the urgency to bend the cost curve, Congress should avoid blunt changes that reduce quality of care. Using benefit design to encourage the utilization of high-value services and deter access to low-value services can improve health, enhance personal responsibility, and reduce costs. I look forward to your questions.